Okay, guys, good evening. Today I think this will be our third session, if I'm correct, for the lower extremity and lower extremity disease. This could be our final session because the exam in 2 weeks, and fellows, you want me to talk about venous disease. So maybe today will be the finals for the arterial. Arterial is very long. Maybe next week we'll start the venous. Because the exam in 2 weeks, maybe I'll try to do 2 sessions a week, maybe Tuesday and Saturday. So we'll have 4 sessions before the exam, because the exam, I think, on the 2nd of December. So next session will be Saturday, then next Tuesday, and then Saturday after. So we have today and 3, so we have 4. So today we'll do as much as we can on lower extremity, and then the 3 session will be for venous. Okay, this is here's a fellow request. All right, let's go and start. You want to start, Abdullah, or are you still on vacation?
I'm still on vacation بس I can't start.
عم تدرس مو صح؟
ايه.
خلاص, go ahead.
Okay, a 70-year-old woman present to the emergency department with cold, pulseless right leg with symptoms starting over the last 8 hours. She had history of diabetes, hypertension, and congestive heart failure with ejection fraction 35. On examination, her pulse is irregular and her right foot is cold and mottled with diminished sensation and weak dorsiflexion. Her right femoral and pedal pulses are absent, and her left femoral and pedal are intact. She is taken to the operating room emergently for right femoral cut down and Fogarty thromboembolectomy with successful removal of the clot and reperfusion. The calf is mildly swollen and on reperfusion and closure of the arteriotomy with palpable pedal pulses. What is the indication for the performance of 4-compartment calf fasciotomy in this case intraoperatively? A. طبعا this is acute limb ischemia to be successfully treated with thromboembolectomy. She present after 8 hours, and this is an indication for fasciotomy more than 6 hours. So the second thing also the swelling of the leg after reperfusion. This is an indication for fasciotomy. So
Okay.
going to the choice.
What is the most important part? I mean, how we decide if it's fasciotomy or not? Is the timing? Is open approach? Go through them. What do you think the most important? To make your decision.
To make the decision, the duration of ischemia. If it's more than 6 hours, this is increased risk of reperfusion.
Right. So the reason why if you have an ischemia, especially acute ischemia, more than 6 hours, it's going to do prophylactic. So the timing is the most important, right?
Yes. Yes.
And this patient has been here for 8 hours.
Yes,
correct?
sure. Yes, right.
So that's the reason why. So the indication for this one is the most important is the timing, duration of the ischemic time. Open approach for the repair, I don't think it's
no.
Yeah.
Present of atrial fibrillation, no. Loss of distal pulses after reperfusion, no.
Because why? Because if you lose it, then it's too late, right? You should do fasciotomy before. If you lost the distal pulse, then really now you're talking about really very delayed ischemia. Because the whole idea is that you want to do the fasciotomy before you lose the pulse. Pulse is a late sign. What is the first sign? You see it?
In patient with compartment?
Yes. What's the first sign we see?
Pain out of proportion.
Okay. What about physical exam? What do you see in physical exam? What's the thing we lose? Is arterial sensation or motor?
No, first sensory, define motor, define touch and proprioception. This is the first thing to be lost.
So the moment you see decreased sensation, you have to go interfere. Don't wait for the motor. So what I'm trying to say is that if you have a decreased sensation, even if the motor is intact, pulse is intact, everything is intact, this is a sign to tell you go and do it as soon as possible. Okay. And usually, where's the sensation you really lose it? Which part?
The
What is
forefoot,
the nerve? What is the nerve most common damage with a compartment?
the peroneal nerve.
Yeah, peroneal nerve. Peroneal, supply sensation of the anterior aspect of the foot, right?
Yes.
So you can expect most of the time is the decreased sensation in the anterior aspect of the foot. So the moment you get that, then it's a sign that he's getting compartment syndrome. So don't wait until you lose the pulses. It's a late sign, All right.
Yes.
Next one.
Pain out of proportion to the clinical examination. So
Yes.
this is يعني post-op. We are still in intra-op. So no, I will go with the duration of the ischemic time.
Yeah, but pain out of proportion to the clinical exam could be a compartment syndrome, but could be something else, right? Could be like a hematoma. It just give you a lot of pressures, It's not always a compartment. So maybe neuropathy. So, but I mean, the most important for us is the time. The reason why, again, if you ischemia more than 6 hours, then you have to do prophylactic fractionotomy. So the most important really factor is duration of
Time.
ischemia. You're right. What about the pressures? Some people they go with the pressure. Some people they go with the time and clinical exam. This is enough. And 99% is enough. Some people it's like a questionable. Like you go with patient, sensation is normal. There's some tightness, but not very tight. It's
Yeah.
like ischemia, like 4 or 5 hours. So you're not sure about compartment. And you can see some cases you're like borderline. So what you do in this case is the borderline
Intracompartmental pressure.
measure. So
Yeah.
right.
If it's more than 30.
Have you see it or not?
Yeah, I do it.
Okay. How you do it?
There is device connected to the needle and syringe filled with saline around 5
Whoa.
cc. You insert and you push the saline, and the pressure will let the device reading the intra-compartment pressure. If it's more than 30, this is indicates yes, there is compartment syndrome.
You know what's the name of the needle?
I forget. I use it. I have a picture of it also, but I forget the name.
Where did you use it?
In Shemesi, in my rotation there.
Because King Faisal, we don't have it, right? Or we have it. I know. I never saw it in King Faisal.
Also,
But I
there
use it.
it is for trauma service. We borrow it from them to use it.
Yeah, orthopedic injury is supposed to have it. It's not striker.
Okay.
Yeah, striker needle, as you said. If you don't have this needle, what do you do?
How to measure, you mean?
Yeah. Well, it is expensive, expensive instrument.
We can do the same needle connected to the pressure.
The arterial line, especially
Yeah.
if you're in the ICU, they already have the arterial line set up, like the one they for radial. Just put a needle and connect with the arterial line. I read the pressure. You need just to zero it. The most important to zero it. But yes, you can use the arterial line. But again, I mean, all this one when you have a doubt, it's like very borderline. But if you have a good, strong clinical indications, then I don't go with the pressure. I don't care with the pressure. Then I take it. Like if patient has like more than 6 hours, ischemia, and the cuff is tender, I measure the pressure came like 15. Would you do fasciotomy or no?
I will do.
Go
If clinically, yes, I will do fasciotomy despite the pressure.
Correct. So this pressure help you only if you're like a borderline, you're not questionable, you're not sure, or sometimes like you have hematoma, because hematoma give you sometimes same pictures, so you're not sure this is a compartment or just a hematoma, especially if you have like a surgery, then this may help you to make a diagnosis. But if you have any doubt, always better to do a prophylactic fasciotomy or negative fasciotomy than miss compartment syndrome and end with a permanent nerve damage. Okay. So what the normal usually pressure? The compartment.
It's usually less than 15, but if it's more than 30, this is compartment.
Okay, this is good. All right, this is good. Let's go to the next question. Who is that? Ahmed. Am I going to take next question?
Okay.
Okay, let's go through
Which
that.
of the following is true for the technique of calf fasciotomy?
Okay.
The lower leg has the three compartments wrong. The most common injured nerve in fasciotomy is the deep peroneal, usually the superficial peroneal.
Right.
A skin incision of 8 centimeter is adequate. We usually make them 15 centimeter, around 20 even.
Correct.
The common deep superficial peroneal nerves can be protected from injury by terminating the proximal extent of the fascial incisions 4 to 5 centimeters. Yes, correct.
Okay.
All compartments of the cuff cannot be decompressed using a single incision. There is a new technique using a single incision. I don't know exactly how it is done, but there is one.
Okay.
I would choose D.
D is correct. First, we have how many compartments? We have 4, right?
Yep.
What are the 4?
Posterior, deep, and superficial, lateral, and anterior.
So how do you fasciotomy? How you put your incisions?
We do 2 parallel incisions on either side
Okay.
of the leg.
Yeah, but where's first one exactly you put it?
With the first one, the lateral one, in between the anterior and lateral compartments, in the
All right.
septum in between, and the medial one, and just posterior to the tibia. You incise
Okay.
the septum and you go to the deep compartment. You separate them.
Oh, that's correct. Yeah, this is the most, and you need a long, the most important that the common, peroneal nerve give you to the deep and superficial. It's exactly at the neck of the fibula.
Yeah.
So when you go, because you go blindly with the scissor up and down. So when you go up, don't go all the way up to the head neck of the fibula. Try to stop at 4 or 5 centimeters. So when you do fasciotomy proximal, don't go too high. Is the whole idea for this question. Because if you go too high, you can cut the peroneal nerve, and then end with a foot rub. This way you can go as much as you can. And always,
Dr. Samer, the voice is gone. Cannot hear you.
I know. Sorry. Yeah, sorry. Yeah. So what I'm saying is that when you try to go distant, no problem, but don't go proximal too high. Is the most important. Try to stay about 4 or 5 centimeters from the fibula head. For the incision, it's simple, really. I mean, I don't like it, but some people do it above the fibula. Because fibula separates posterior from anterolateral compartment, right? So if your incision lateral of the fibula bone, then you can raise the flap anterior, you can access to the anterior and lateral compartment. If you raise the flap posterior, you can access to the deep and superficial compartment. You see that? You follow me? So the single incision is usually above the fibula, lateral of the leg above the fibula, and then you raise the flap, skin flap, anterior, posterior, you get access to the anterior lateral compartment and posterior deep and superficial compartment. Okay. But I don't like it. I like to do incisions, and the most important to make it a good incisions, because the worst thing to make a small skin incisions. Or after you do fasciotomy, I see people close the skin. You have to keep the things open. They release the pressure. Is the whole idea. All right. Any question about compartment? I know they like these questions. All right. Let's go to Bara. The next question.
Yes, Dr. Samer.
Let's go to this one. All right.
68-year-old female patient present with non-healing diabetic foot ulcer 1 centimeter in diameter on the base of the first metatarsal head for the last 2 months. The ulcer is deep, extending to the subcutaneous level with minimal drainage. Dr. Samer.
You see? You lost it? Sorry.
Yeah.
You lost that, right? Sorry. Yeah, not that. Sorry. Where is gone? Here. You see it now again?
Yes, now it's clear.
Oh, yeah. Let's continue. Yes.
The ulcer is deep, extending to the subcutaneous level with minimal drainage and no cellulitis. She has a prior history of claudication 1 year ago and developed this ulcer in the last 2 months. Her hemoglobin A1C is 7.8. and she is working with her primary care physician to get a better glycemic control. She is using an offloading wedge heel shoe and is willing to see an orthotist for custom shoes. She has hypertension and hyperlipidemia as additional comorbidities. She lives independently at home and works as a freelance writer. Her risk analysis index frailty score is 30. Her ankle brachial index are non-compressible and toe pressure is 27. Her diagnostic angiogram finding are shows in figure 1 and 1b. The patient has a single segment greater saphenous vein more than 3 mm in size from the saphenofemoral junction to the midcalf on a vein mapping. Which of the following is true in the management of this patient?
All right,
So-
let's look at the angiogram. Let's go to the angiogram. What do you see in the angiogram first?
B3 is patent, anterior tibial is patent, tibio-peroneal trunk is patent.
B3 is better? No, it's B3 is occluded.
No, the distal segment of B3.
Yeah, it's occluded. Okay.
Yeah.
And you see single vessel off.
I think there is a posterior tibial distally.
Yeah, but what's the main run off? It's a foot. What's the main artery?
Single
that
artery,
peroneal?
posterior tibial. Peroneal, this one.
Peroneal, right? This is peroneal here. I'll give you a branch to posterior tibial. Posterior tibial, this one. But you have peroneal, give you the branch to the posterior
Posterior
artery, right? So this is peroneal artery, right? And you have occluded pubic artery, okay? So let's go back to the history. A lot of information, you know. So is 68. She is not, you know, it's not too old. She's very active. She has an ulcer, right? So need to fix
Yes.
it. It's not like she's chronic and she has an ulcers.
Yeah.
Um,
She's clodicant for 1 year, and now she's having critical limb-threatening ischemia with tissue pressure 27.
Yeah. What is that risk analysis score? You know what is that? Risk analysis index facility. Frailty score is 30. It's important information. So, yeah, how do you calculate? This is a special, you know, like you can application you can do it for risk analysis. It gives you an idea about the short and long term, you know, outcome of the patient, morbidity, mortality, hospital stay. All they go through the risk analysis index frailty score. So you know what acceptable score to do a surgery? Because it's an important score, guys, to use it. We don't use it quite often, but I think it's good to get to use it. Dr. Isam, Allah yarhamu, he used to use it a lot when he make a decision, is the patient fit for surgery or not? So if you use this risk analysis index, it help you a lot to figure out if the patient fit for surgery or not, you know, because it depends on his past medical history, it depends on his comorbidity, you know, his age, diabetes, hypertension, it's all like you put them there and end with a score. That usually the score is 30 and above, considered as high risk for surgery. 30 and below is considered feasible, is acceptable risk for surgery. So when he tell you the risk analysis index relative score is 30, that means he's a good candidate for surgery. But if he tell you like they go up to 80 or 81, I think, I remember. So if he tell you like, you know, that his score is like 70, then he want to tell you don't think about surgery, think about endovascular. But when he gave you score 30, that means surgery is an option, okay? And the second thing he gave you is that a single segment greater saphenous vein more than 3 millimeters. So he take you to which trial? Best CLI trial.
Best CLI.
Yeah, so he want to tell you, you know, this is because this is exactly what best CLI should be, a single segment greater saphenous vein more than 4 millimeters. This is the best CLI, okay? So he give you a hint that he wants you to apply the best CLI, you know, conclusion on this patient. So we have a good vein. His risk analysis index is 30, so he's good candidate for surgery. And then he has a reason to do a surgery because he has an ulcer. So pressure is 27, you know, so it's very low. So, and you see an angiogram, he has single run off, so it's not a place to play with endovascular, right? He's only single run off. And in pubic is the worst time for place for endovascular. So really what he wants to tell you, what do you think the best management for this kind of patient before we go through the question?
Fem distal bypass.
Yeah. But why fem? Why you have to go to femoral? Popliteal is there, right? Above the knee. As far as I didn't show you proximal, you have to presume is normal. Yes, could be occluded, could be disease, but as far as I didn't show you, then you have to presume everything above is patent. So why I should go to femoral? No, I do popliteal above the knee to the peroneal bypass. Short bypass. The shorter bypass always is better. All right?
Okay.
What else is anything? The questions. So let's go through each one. Let's go. Okay, so first one.
So her Wi-Fi stage is wound 1, ischemia 0, and foot infection 0. No, she has ischemia. She has foot infection.
Okay,
She has
so the wound is what is deep, 2 centimeters. So this is 1 or 2. This is 2, right? Because the deep.
Yeah.
Where is it? Ulcer is deep. See, it's deep.
extending to
So
the
deep diameter
subcutaneous area.
Ischemia is not 0 for sure because you have a severe ischemia here. You see an occlusion, and then you see the pressure is 27, right?
Yes.
So anything below, 30 is considered, I think, if I'm correct, ischemia 3. I think. Wound infection is 0. Yeah, it's no infection, infection, so 0. So this muscle will be wound will be 2, ischemia 3, and foot infection 0. Okay.
Okay.
So guys, you need to read the Wi-Fi. It's simple. It's not complicated, but I'm sure you may get a question in the exam. So it has to be. You have to know about Wi-Fi classification, and he may give you in the exam like what the classifications. So you have to know the classification. So this patient will be 1, 2, ischemia 3, and foot 0. Okay.
Okay.
Okay. Let's next one.
The patient has microvascular disease, and revascularization would be unhelpful in preventing limb loss. She has macro and micro, but she still needs revascularization.
Correct. So this is normal. Okay.
Yes. Yes. See, an endovascular first strategy has a better freedom from major adverse limb event and death. No.
Not in this patient. Like again, I mean, if he gave you a patient like he has no saphenous vein, he is like, risk analysis is more like 40, 50, then yes, endovascular may be good here as a first options, But because this patient has good vein, it's good, risk for surgery, then bypass is better.
Mm-hmm. The popliteal peroneal bypass has a patency equivalent to an inframalleolar bypass.
Definitely, like what he wants to tell you that if you do bypass to here, or you do it to the inframalleolar to here, will be similar bypass, similar. Because, and why he tell you this one? Because some people, they said, why I should go to the peroneal and depend on the branch for, let me go to posterior tibial, do like popliteal posterior tibial bypass, You can do it, but really doesn't make a difference because you have a nice peroneal artery and a good branch and go to peroneal. So if you do it to the peroneal shorter one here, will give you the same outcome as if you do it all the way up to here. They're talking about this patient, they're not talking in general. They're talking about this patient. This patient, if you do popliteal bypass, patency is equivalent to intra. Yes, it's equivalent. If you do it here, or you do it because peroneal is nice and you have a good branch here, you see? But if it's peroneal disease, then I'll do to posterior tibial here. But because peroneal is very nice and inframalleolar artery is here, the posterior tibial here, the malleolar is here, or do it here, I think it's better always to do it to peroneal because it's a nice artery. Okay, is it clear? The question is very tricky a little bit, the way they put it. But the whole idea is that for this patient, I will do popliteal to peroneal bypass for the pain. It's the best option for this patient.
Sorry, Dr. Samer, I got your point regarding bypass to the peroneal artery, but why not to the posterior tibial?
It's not why you can do it. It's equivalent. This is answer D. It's equivalent, right? Sorry. Popliteal bypass has patency equal to the inframalleolar bypass. Yes, you can do it. It's just preference. It's not like you did this wrong. But it's a bit longer bypass, so it's okay. Yeah, you can do it. Hatem technically is easier because peroneal is deep,
Yes.
But I mean, you can do it. It's not like you cannot do it. So you can go both way. The reason why this is equivalent. So if somebody answered popliteal peroneal is correct, and if somebody said popliteal to posterior tibial in this case, I think it's correct. All right.
Oh, okay.
Any question about this question? Any question?
Mr.
No, thank
Samer,
you.
in many texts, they consider peroneal is not inline flow.
Sorry?
Many texts suggest that bypass to peroneal is not considered an inline flow.
This is correct. But I tell you, there's a reason why I'm saying the question is to this patient, right? Because muscle
Yeah.
peroneal, like you see here, like you could see same patient here, and you don't see the small, I just posterior tibial. You don't see the small connection here. Then yes, I agree. Then I'll go to posterior tibial. But in this patient, it's just everything the same, right? If you do here or there. So why you see his nice artery? What I'm saying, the question is not very good, really. You know, but yes, I agree with you. If you have a nice posterior tibial, I'll go to posterior tibial. But if you have peroneal like that and have a short vein, for me, popliteal to peroneal will work fine. But if you go to posterior tibial, yes, always posterior tibial is better. But the only thing you have to also be, you know, if you do it here, you get more flow to the proximal part of the leg. Where you go distal, most blood flow go down, but you can go retrograde. I mean, it's no question. I mean, yeah, I think you can go either way. In this case, you can go either way. But rarely you see this picture. Always you see like, you know, the collateral from the peroneal is disease. So better to go to posterior tibial. But in this case, he confused us by giving us a beautiful artery and beautiful branch going to posterior tibial. All right. Let's go to 28. Where's Osama?
Yes, Dr. Samer. Which of the following statements is true regarding epidemiology of chronic limb-threatening ischemia? Okay.
Oh, it's
Black-
not yeah, it's like American question. This one you don't have to know about, but you can go over it very quickly.
Okay. Black patients presenting for revascularization are more likely to present with critical limb ischemia than white patients.
This is correct. The reason why, because black people are poorer and they have a worse insurance. They don't go access to the good hospital. So this is study they found always black patients they come like more late. So again, all statistics. These are American statistics, so you don't have to worry about it. Let's go next one.
The volume of revascularization done at facilities has no effects on limb salvage rates.
Well, this is wrong, right? Because of
Nice.
course, if you have a patient's high volume, they will do much better outcome than people because the under high because they access the endovascular, the open, so they have more technique. Where hospital they don't have high volume, they maybe just do surgery, have no access to endovascular, no access to drug-coated balloon, no access for a theraptomy. So always high volume hospital, you get better outcome and better limb salvage because you have more tools to work with it.
Yes. C,
Okay.
insurance status has no impact on amputation rates and critical limb ischemia. For sure, it's wrong.
Yeah, this is wrong. Yeah.
D, the prevalence of diabetes and critical limb ischemia is 30%.
It's small, right? Because people that come with a critical limb ischemia, the majority have diabetes, right?
Yes.
So it's small. It's like about 50-60%. So people with diabetes and critical limb ischemia is very high. So 30 is low, really. So his answer would be A. But again, it's not a good question. So don't worry about it. Let's go to the next question. Let's go to this one. You can take this one. Sama?
Yes. Okay, that's Sam. A 2-month-old newborn in ICU with extracorporeal membrane oxygenation, ECMO, cannula in the right femoral artery, has the new signs of acute right limb ischemia, including a pale, cold extremity, mottling of the skin, and absent arterial Doppler signals. The patient is ventilated and on heparin drip, and 2 pressors. Which of the following regarding management and natural history of this patient?
Okay, this is a good. We see a lot. We get a lot of on call like this people, 2 months,
Yes.
old. in general, in pediatric patients, you know, they tolerate occlusion very well. Even femoral artery, iliac artery occlusions, they tolerate it very well. So the treatment in young,
Exactly.
very neonate or very young is conservative, just heparin.
Yes.
Even if you have a little ultrasound of occlusions, they still do very well. Okay.
Okay.
The only problem when you get the problem is they get older. When they get older, you know, then remember the kids they develop, right? So what happened if you have an occluded artery? And again, you got to have you don't see ischemia because of a good collateral system, you know. So what happened? You're going to see discrepancy in the limb length because one of the limb has less flow than the other, and the baby is growing. This is the time the baby grow. So circulation is important for growing. It doesn't affect us as adults, but in young people it affects them, especially in very young age. So in the future, you may see some discrepancy in the limb. So if you start saying that, then you may think, not now, later on, you may think you have to fix it, open the artery or do bypass, whatever, when they grow up. If you start seeing some discrepancy or they develop any symptoms. But in acute stage, always try to be conservative, you know, as much as is heparin and wait, you know, even with the
Yes.
occlusion. Okay. All right, let's
Yes.
take one by one.
So yes, A, the patient should be taken to the operating room for removal of the femoral cannula and reconstruction. This is wrong, as we mentioned that it should be conservative management at this age, pediatric in general. Pediatric patient rarely need delayed arterial repair after iatrogenic vascular injury. Rarely need. Yes.
No,
Yes.
it's
Rarely
correct or
need
no?
delayed arterial. They rarely need delayed arterial repair after agenic. No.
Why no? Because it said, you see, the more you have injury in the pediatrics, in younger people, most likely going to have more delay repair because they can affect their growth. Whereas if you
Yes.
have it in older patients and they pass the acute, most probably they will not need it. Like I give you an adult. If you have an occlusion of iliac artery has good collateral, right? You're not going to do anything, right? There's no complications. But in young people, even if they have no symptom, if you start seeing discrepancy in the growth of their leg, then you may consider it. So the more you have occlusion in the pediatric group, most likely you have to do something later on because it's going to affect their growth. But if they have it when they are 10 or 11 years old, then they already passed this growth, you know, the surge of the growth of the limb, then most probably you don't need to interfere. So it's just like, you know, the percentage. The pediatric patient, most probably they will need arterial repair later on. The younger they have the injury. The older they have injuries, the less likely they need more later repair or delay repair. Okay?
Yes. C, younger children are more likely require delayed arterial repair.
It's the opposite.
Yes.
Younger, this is pediatrics, right?
Yes.
No, the younger patients are more likely, no, less likely. Because it's younger children, not pediatric. You difference between younger children and pediatric. See, pediatric is growing. Children now, it's like 10, you know, 9, 10, 11. So less likely to require. But pediatrics, they most likely to require it. You get the point? It's very
Yes.
tricky questions, you know. But the whole idea is that the younger is a baby, is a higher chance that he need a delay arterial repair, but not on the acute stage. Okay.
Okay. The interrupted suture with spatulation of the involved vessel so as to create avoid anastomosis will lessen the risk of later narrowing of the anastomosis.
Yeah, in general, always in the kids, if we have to do a repair, this is in general, not talking about this case, you know, talking in general. Always, if you have to do repair for some reason, always we use interrupted stitches in the kids because they grow. If you do running, you get a stenosis. If you do interrupted, then they can dilate it with a growing of the baby. So always in pediatrics, we do interrupted stitch. We don't do running suture when you do anastomosis. You do it in a beveled way, so you decrease incidence of stenosis. So this is the most common result answer. Okay.
Yes.
Any question? The whole idea is that, guys, pediatric group try to be conservative for acute. Forget about late comes later on. So pediatric group, always try to be conservative, even with acute occlusion, even if the iliac is threatened. Most of the time they respond very well. Unless it does not respond, then you may have to take them. But the problem, if you take them, they usually occlude again. So try to be conservative as much as you can. And if they pass the acute stage, most likely you need to do something in the future if affect their growth, limb growth in the future. All right.
دكتور حتى لو كان الاوكلوجن مثلا في الكومن ايلياك اكسترنال ايلياك بروكسيمال.
Yeah, it doesn't matter. Yeah, even it's common iliac, external iliac, doesn't matter. They do very well. I say kids, they do very well. Because artery is too small. When I first came to King Faisal, I didn't know I was aggressive, so I used to take them to surgery, but they just clot it next day. Because they go to spasm very easy. They go to spasm, they clot it, you know. Then I stopped doing that. I just consulted, and majority they do very well. Okay. All right. Well, let's go to the next question. Well, Yahya, you want to take this question? Let's see what this question. Okay. Yahya, are you here? I saw your name. Maybe he's on call. Maybe he left. Okay. Well, let's go back to Abdullah.
Yes. A 42-year-old man present with left calf claudication with walk 100 to 200 yards on upstairs. He is a non-smoker and he has no other medical problem. He has palpable femoral and pedal pulses with no pulsatile mass. His ankle brachial index are 1, the right with the triphasic wave, and 1.1 on the left with the triphasic waveform at rest. Exercise ABI showed sustained drop in ankle pressure and non-recovery at 5 minutes on the left leg. The left pedal pulses is obturated when the knee is flexed. The imaging duplex figure are shown. What is the management of this case?
Okay. Well, let's see what this case.
Okay.
It's a tough case, really. Yahya is not here. He got lucky. He ran away from this case. But okay. So what we see here, first patient is normal. Okay.
Yeah.
He's
What can I
medical
say?
problems.
Yeah.
Yeah, it's a good film. This is pulses. ABI is normal. The only thing when he flexes his knee, the pedal bus go away. Okay.
This is feature of cystic disease.
How do you know? Why not poverty aneurysm?
Because he said there is no pulsatile mass.
Okay, correct. And second thing, you see the artery is normal here, and this is here. It's like a cyst. It's not like thrombosis. You see, it's like a cyst.
Yeah.
It's not a thrombosis, right? Where's the most common area for the cyst, adventitious cyst?
It is the popliteal artery.
And next.
والله ما أدري دكتورة. What I know it's
popliteal. Then iliac, then external iliac, then radial, ulnar, brachial, all of them. But the most common is really popliteal, then femoral.
Yeah.
So iliac كمان. But popliteal is the most common. It's majority of like an 80-85% of the cases is popliteal artery. All right.
Yes.
So why is not entrapment syndrome? Popliteal entrapment syndrome. Why you thought about that popliteal entrapment syndrome?
Yeah, the feature with knee flexion, disappearing of the pulses, this Ishikawa's sign, it is going with cystic. While absent of the pulse with the dorsal or plantar flexion, this is going with popliteal entrapment.
Okay, so what's the sign name?
Ishikawa.
Ishikawa, yeah, from Japan. Yeah. I wish you have a sign with our name. All right, let's see what. So what's the treatment?
طبعا trial for aspiration, this is risky and recurrence is there. So going with if it's asymptomatic, if it if not affecting the artery, we can do resection, primary anastomosis, or excision of this is complete excision.
without replacing the artery.
Yeah, if not affecting the artery. But if it affects the artery needs to be repaired.
Okay. So especially asymptomatic, you go and fix it?
Asymptomatic? No.
Yeah. Yeah, they need to fix it, right? Why need to fix it? Asymptomatic. Just because it's there. The only time you need to fix it is when patient symptomatic, right?
Yeah.
And you can't just take the cyst. You have to take the whole artery because the whole artery is disease. So you cannot just take the cyst and leave the artery. Even the artery is still patent and nice because it's adventitia, right? So if you open and take the adventitia, the artery becomes very thin. It may cause a problem and in the future. So always cystic, you have to transect the artery and put into position vein graft. Okay? If asymptomatic, we leave him alone. So the question is, what approach?
What is the management of this condition?
Now, what the approach? How you do interposition? You do above, below, above the knee, incision, below the knee.
I think posterior approach.
Yeah, posterior approach because this is B2, right?
Yeah.
So the best way is to do just resection, interposition, vein graft, reverse the vein graft with inside too, because it's better outcome. He's a young guy. Why should do bypass and ligation, all the things? So the best way is just posterior approach, like popliteal entrapment syndrome. But in this one, you don't just release the muscle. It's not enough. You have to resect the artery with interposition vein graft, okay? Because the artery is disease. When in entrapment syndrome, you can just cut the muscle. If the artery is fine, you can leave it alone. But in this case, in the cystic media adventitial disease, it's better to resect the artery and put interposition vein graft, okay?
Okay.
All right, let's go through the question with the answers.
A. Endovascular stenting of the popliteal artery. No.
Okay, of course, yeah. He's young guy, yeah.
Watchful waiting with supervised exercise therapy. No, he's symptomatic.
Okay.
Popliteal artery interposition repair using posterior approach and reverse saphenous vein graft. This is one of the options. D. Release of abnormal insertion of medial head. This is not popliteal entrapment.
Right.
Medial approach bypass for above knee popliteal artery to posterior tibial artery. No, we can exercise without doing bypass.
No, it could be correct, but what he did to make it not correct, because you can do above knee to below the knee. You cannot say it's wrong. It's not the best, but you can say wrong. But why is wrong this one?
Why is wrong? Because we don't, still we did not remove the cyst.
No, it's okay. You can do bypass. I mean, you can. What the big deal? Why need to remove it? The problem is occlusion, right? So you can do a bypass. So why need to remove it? I mean, I'm saying it's the best, but it's unacceptable. If somebody tell me, okay, I just go and do bypass, that's okay. Why instead of put it inside too, I do medial approach, I do bypass.
Yeah, he's young patient. This is first one, I think.
Bypass working. Read the question E again. Read it carefully. What they say?
Medial approach bypass from above knee popliteal artery
to
posterior tibial artery.
Yeah, see, posterior tibial.
We exclude everything. بس
why posterior artery is small? This one, the patency is very low because you go to the branch. If you tell me above to below the knee popliteal, yes, then it will be acceptable. But because popliteal artery, you're still doing popliteal to popliteal. Like the same, it's a different approach. Instead of doing posterior approach, you can do above to below knee popliteal bypass with the vein graft. But when he put posterior tibial, this is wrong because if you do to posterior tibial, the patency is very low because now you do it, to the single artery, which is small, 2 millimeters. So patency will be really low, okay, or 3 millimeters. So this would be make it wrong. So the best option is said to go to the C, okay?
Yes.
All right. Any question about this? I mean, it's very rare. I never saw. I don't know if I saw one case in my life or not, but I don't think I saw any case. It's very, very rare disease.
Dr. Samer, it's mentioned in some sources there is a rule of aspiration, and the other thing, rule of only resection of the cystic mass, cystic lesion. So do we need in such cases just to remove the cystic without doing bypass of the artery?
But like Sam, I be frank with you, I never saw any cases, so I don't have experience with these ones, you know. But if I go there, if I have to go, I mean, aspiration, I may try it, you know, but I think they will recover because this is a congenital cyst, so it has an enema, so it's going to secrete fluid again, right? So in my things is that if you try, you can try aspiration. I mean, if it works, it works. But if I have to make a cut and open, I went all the way there. I will not just go take a cyst and take it out. So what if it doesn't work? Then I will do intervention vein graft, you know. But it could be an option. The reason why they didn't put it here, so it could be an options. If they say it, again, this is must be their preference or the preference. I think if you want to try aspiration, maybe it's not a bad idea because it's simple. Just put in aspirate. If it works, it works. If it doesn't work, then you go there. But if I go there, I have to make an incision. You can try to take it out, but I prefer intervention vein. As I said, I mean, in medicine, nothing like black and white. Always what is the best. I think is that if you have to go there and make an incisions, give him the best surgery. And does not make a difference for him because same incision, everything. Why should go and resect it? This is the way I look at that. But if something like gray like that, they don't put the question. The reason why they didn't put this in the question because it could be a possible, you know. So that's why they give you like very good answer for that.
Okay, thank you, Dr. Samer.
You're welcome. All right. Well, let's go to next one. I know what is that. Let me just show you the artery and the cyst. Let's put 31. Wait, Ahmed, we go back to you, Ahmed.
Okay. I've got a 65-year-old man presents at the emergency department with sudden onset, severe pain, pallor, and coolness in the right lower extremity, acute. The patient recently underwent cardiac catheterization for myocardial infarction via the right radial artery. Upon examination, the right foot appears to be cyanotic. The right femoral pulse is not palpable, and the dorsalis pedis and posterior tibials are absent, in addition to motor and sensory deficit. 2B. The patient denies previous episodes of claudication. Laboratory tests show that elevated D-dimer and CK. Which of the following is the most likely etiology for the patient's clinical presentation?
Okay, so this young guy, 31.
65, not 65.
65, right, sorry. And he
And
has
MI patient, most likely it's a cardiac embolus.
same emboli, right? Yeah. And that's why he told you right that he didn't tell you, if he said the femoral active has a PCI, and he didn't mention the radial was femoral. I was thinking first about femoral occlusion from the PCI, correct?
Or dissection, yeah.
Or dissection or closure device or trauma or lung, you know. But because he said radial, then he want to tell you we didn't touch the femoral, okay? So don't think about it. Because if it was through the femoral, my answer would be the first, plaque ruptures, you know, or maybe closure device failure or something like that. Because he didn't come, then it has to be an emboli, you know. An emboli, the most common come from where? From the heart, correct?
Yes.
It's an easy question, but you can go through it.
Plaque rupture, that is if the patient has chronically claudicant, then it became acute. Aortic thrombus is possible, but again, we cannot assume something that is not there.
No,
Deep
look at
vein.
that, Ahmed, before you go, you have the question. What the most likely? All of them could be, but they want to do most. See, so doesn't mean they are wrong. They're correct. Any of them really could correct. Even this one could be a plaque rupture for some reason. He has a stenosis we don't know, and plaque for some reason ruptures. You know, but what the most likely? See, so you have to understand what the question. So what the most likely it would be a thrombus, but really all of them could be an ACS, but the most probably is a thrombus. Yeah, but let's go through them again.
And then C, deep vein thrombosis.
Yeah, it's less likely because they come with a cellular dolence, yeah? And it's not a sign. It's a cold like here. It's not, you know.
Yeah, paradoxical. And then intracardiac thrombus. This is the most
Okay.
common known. And then
Yeah.
arterial access, this patient had radial right-sided.
Correct. So it's not that. Yeah. I mean, it's a simple question. Again, I see sometimes, guys, it's good. Like, question could be simple. Don't go think that every question has to be difficult. 80% of the question has to be straightforward. 20% maybe could be quite tricky. 80% should be just straightforward. So don't be scared to answer something. Just makes sense. All right, let's go to the next one. So this is a simple one. Let's see to this one. Barra, you want to take this one, Barra?
Yes, Dr. Samer.
Go ahead.
A 65-year-old man presented to the emergency department with more than 12 hours of right lower extremity pain. He stated that he went to sleep with mild pain over his right leg that appeared while he was watching the TV. The pain got worse overnight, and when he woke up in the morning, he started feeling numbness in his leg. He still moved his leg, his right foot, and toes without limitation. He has atrial fibrillation and was taking warfarin until the day before. His laboratory value are normal except for an INR of 1.6. CTA was done, which revealed below the knee popliteal occlusion with no tibial blood flow. He has no recent trauma, surgery, cerebrovascular event, or hemorrhagic episode. What is the recommended management strategy? So this is a 65 male patient with AFib, and he is having acute limb ischemia, Rutherford 1.
1. خليك شوي في كريم شوية.
2A maximum.
Yeah. Because I had sensation. It some has some sensation, right?
Mm.
But the motor is still intact. He started feeling some numbness in his leg. So he started having, there's a way. 1 is no numbness,
2A.
right?
Yes.
It's normal. So he has some numbness. So he's starting now 2. And motor is function is none. So it's 2A, correct? So 2A,
Yes.
what usually we do? Do we do endovascular thrombolysis or open?
No, you can do thrombolysis, but better to do open thrombectomy through popliteal exploration.
Why? If you have something, we are in the 21st century. Why you should go to open if you can do thrombolysis? It's 2A. It's no motor. You still have a time, right? I'm not saying it's wrong. See what is recommended. You see, you have to answer the question. He didn't say what is the best. What recommended? You can recommend it, but doesn't mean the other is wrong. I mean, our exam, if you tell me an open thrombectomy, it's okay, But tell you what he tell you here. He said no cerebrovascular event, no hemorrhagical episode. So he push you to the thrombolysis.
You want thrombolytics here?
Yes, and he has a point because he's only 2A. It's just minimal loss. Motor is still functioning. If he told me all motor, he can't move his toes. Yes, there's no time because thrombolysis takes 24 to 48 hours. So if he already has neurological symptoms, then he cannot wait. Then you have to take it for open or mechanical thrombectomy, whatever. But if you have like 2A, still like early, then yes, why not thrombolysis? Now, less invasive, just put a catheter. It has no contraindication, no hemorrhagical episode, no CVA, no recent history, no recent trauma. So we give you all the things to tell you thrombolysis is not contraindicated. It is an AFib, so it's a clot, it's not a thrombosis. Just put on thrombolysis, Okay. And the second thing is below the knee. It's like femoral, it's like better. Like below the knee, it's more difficult. And all the studies showed that if you have a tibial occlusion, they do much better, with the thrombolysis than thrombectomy. Because thrombectomy, you can thrombose, you can take only the major clot from the artery, but you can't take it from the small branches. So you don't have a good patency like when you do thrombolysis. Thrombolysis like water, so it go all the way to the branches. So you open really more artery with thrombolysis, more branches. And some arteries, they go to spasm, you can't even pass the catheters. So always when you're dealing with tibial, thrombolysis is much better than surgery if you can do it. When you do with a common femoral iliac, then open thrombectomy thrombolysis the same, then you can both the best. No difference between endovascular and open. But when you deal with the tibial thrombosis, no question is thrombolysis. And many studies show that tibial thrombolysis better than open thrombectomy for tibial arteries. Okay?
Yes.
All right, let's go one by one.
So open thrombectomy from groin incision, no?
Yeah, if he said popliteal incision, as you said, yes, could be an answer, But this is say the groin. You don't have to, because this is below the knee, and tibial are, why you have to do below the knee at the groin? Why not do it from the groin? Why have to go to the popliteal?
No, you need to pass the Fogarty in each tibial vessel.
Yes. So you, but when you go from the groin, go mainly only to the peroneal artery, right?
Yes.
But if you go from the below the knee, then you can get to the axis of all arteries, you can do thrombectomy. Of course, this one, it also can be argued about it, because these days you have Fogarty over the wire. So you can put the wire in each tibial and then go Fogarty over the wire and do even thrombectomy. But it's not that recommended. It's better to go from the groin, from below the knee incision, popliteal artery. All right, next
Yes.
one.
Heparin with intensive care unit monitoring. Also no. Right below knee amputation, no.
Mhm.
Catheter directed thrombolysis of the right lower extremity, yes. Femoral to tibial artery bypass, no.
Okay, it's a straightforward question,
Yeah.
Again, if you put open thrombectomy from, from below the knee incision, could be confusing. That's why he put the groin. All right. Any question? All right. Next to Samer. Go back to you, Samer.
Yes, Dr. Samer.
Okay. Well, let's go to 33.
Okay, 68-year-old man with a past medical history of diabetes mellitus, hypertension, hyperlipidemia, stroke stroke 6 months ago, and atrial fibrillation, present to the emergency department with sudden onset of severe pain and pallor in his right foot for 6 hours. On examination, the right foot is called to touch with palpable femoral pulses, but no pedal pulses or signals and delayed capillary fill. The patient has a sensation deficit in the mid-distal forefoot and weak dorsal and plantar flexion. He denies recent episodes of bleeding. He underwent a CT angiogram, which revealed occluded popliteal artery at the trifurcation, with no flow into the posterior tibial and peroneal vessels, and flow in the mid anterior tibial artery. Which of the following is the next step in management of this patient?
Okay. Before we go there.
Yes, he's a
let's
patient.
say what he has. Mhm.
Yes, comorbid patient, diabetic, hypertensive, history of atrial fibrillation, so it is thrombotic sources most probably, history of stroke, presented with the right lower limb ischemia 2B, and with delayed capillary reflux and ischemia for 6 hours. And the CT showed occluded popliteal artery at trifurcation. So it is embolic source of atrial fibrillation most commonly. So in this question, he's asking about the next step of management, not the
Right.
proper.
So,
So
what do you think is the best, thrombolysis or
no,
surgery?
next step, I will start the patient on heparin fusion, heparin fusion first, anticoagulation.
Okay.
First step. Then after that,
And
I will
then?
proceed for. After that, I will take the patient for thrombectomy, open thrombectomy.
Open or thrombolysis? Is the main question, Haikon.
Yes, for me, I will go for open because he has a 2B.
Okay, what else?
Delayed 6 hours.
Okay, so it's have delayed 6 hours.
Okay,
And then he has also more. He has 2B because it's weak dorsal.
Yes, 2B. Yes,
2B.
sensory motor.
But what's the most important? He mentioned something at the second line. What he said?
Atrial fibrillation or
Oh, before that, stroke, right? 6 months ago.
stroke. Yes.
Right?
So it is
So this is,
contraindicated for thrombolytic. Yes.
yeah. Even some people 6 months, okay, but why should take a chance? So this is one of them. It's not only, but he had a stroke. So this is not a good sign for thrombolysis. It's been 6 hours, so it's a late ischemia. He already has a motor function, it's 2B. So all of them push you. You have to do something right away,
Open. Yes.
So let's start one by one and see what is the best.
Pharmacomechanical thrombectomy with aspiration. No, it is not an option.
Because they put the pharma. No, just a second, Sam. They put, if he did only mechanical, then it could be correct.
Yes.
You know, because mechanical I can open, you know, but he put pharmacochemical, pharma because stroke, then this part would be wrong. So this should be questioned wrong, you know. If he didn't mention a stroke, he just put mechanical, mechanical thrombectomy. Maybe it's not the best option, but some people, they may do mechanical thrombectomy. Because the same, mechanical thrombectomy is like open thrombectomy, really. You just use Aspirex or Rotarex or whatever. If you can, but if you have to give some medications like TBA, which most of the time you give a TBA because mechanical thrombectomy usually alone is not enough, especially if you have like a lot of occlusions. So because he has a stroke, then it's contraindicated or relative contraindicated. So, but this is not a good options. Okay.
Okay.
Next one.
B, open thrombectomy from the below-knee incision. I will do thrombectomy selective for the popliteal. If I will do thrombectomy, I will do it from below-knee incision for as selective for popliteal.
So this would be a good answer. Yeah.
Yes.
Okay.
C, catheter-directed thrombolysis. As we mentioned, he has history of stroke, so most probably it is. If it is not absolute, it is relative contraindication. D, atherectomy of the affected popliteal segment. No, he has an acute ischemia, so and the trifurcation. Systemic anticoagulation, for me, the next step will be the systemic anticoagulation. Then after that, mechanical thrombectomy. So I will.
Mechanical or open? Sorry, you confused me.
No. Sorry, open thrombectomy. Yes.
All right. What is the following is the next step in the measure of these patients?
For me, I will choose systemic anticoagulation first.
I mean, you're going to give it, no question, but you have to take him. But you see.
Yes, I know.
See,
For me, I will do
systemic
anticoagulation
because it may understood that only systemic anticoagulation not take him to surgery. You see, it depends how you look. As I'm saying, some of question they're like placed in bad way. No, it's not good constructed questions because it depends. If you think that I'm going to give him anticoagulant, take him to surgery, it's a good question. Yes, this is the answer. But if you think this to just give him systemic anticoagulant and stop and just treat him conservatively with anticoagulant, this is wrong.
Yes. So if the answer was for definitive management,
شو عم يفكر دكتور عرفت كيف؟ Because as I said, next step just give anticoagulant, yes, but then take him to surgery.
Yes, that's right. Yes.
So I don't know. Let me see what they choose. They choose B. See, because again, in this question, when he put it, he thinks that when he wrote systemic anticoagulant, this is just that means you're going to go conservative, which is wrong. You have to do open thrombectomy. So again, I mean, it's not a good, questions, but in general, this patient needs to go for surgery for open thrombectomy, correct?
Yes, we agree for that.
You're not going
Yes.
to treat him with just anticoagulant, right?
Yes,
no place
that's
for
right.
We have. All right. Let's go to the next questions. Is Yahya back or still away? He's stuck in emergency. He's on call. Right. We go back to you, Abdullah.
Yeah, a 66-year-old woman presented to the hospital with severe chest pain. She was found to have an ST elevation myocardial infarction and was taking emergency to the catheterization suite for successful percutaneous coronary intervention. She had an eventful course until third post-intervention day, when blue discoloration of her right second toe was noted. Which of the following is likely associating finding? This is a blue toe syndrome or trash foot.
Correct.
Yeah, usually these patients have normal arterial system. So it is only, يعني peripheral vascular. This is mainly. Sorry, Doctor.
I agree.
Yeah.
As you said, I mean, you have to pedal pulse open because it's occluded, then it will not go to the toe, right? It will stop somewhere else.
Yeah.
Before. So to go to the toe, the small emboli, because this is atheroma emboli, it's very micro emboli. So to go all the way to the toe, they have to have a patent vascular flow down to. If he has an occlusion, tibia, or tibia, whatever, especially anterior tibia, because they go to the toe, then they will not have a. It's not like cannot have it because you can have them both, but usually in Bluetooth syndrome, patient has a bubble pedal pulses. Okay.
Yes.
Okay. So next, let's go by one, just for the sake of question.
Palpable pedal pulses. This is correct answer.
Okay.
B, right foot sensory deficit. No. C,
Because
right
there's a
foot.
microemboli, right?
Yeah.
That's why we don't have it, because microemboli. Okay.
Right foot motor deficit. Same. No. D,
Okay.
cold foot. No. This is it's only micro. E, claudication. No, this is not a chronic thing. So
That's correct. So how we treat it, Bluetooth syndrome?
we need to give them antiplatelet aspirin, and but we
What
need
else?
to do, yeah, we need first to do for them CT whole aorta, also echo, to know the source of this problem. If there is an identified any source, I mean thrombus, he may need anticoagulation.
If you have a thrombus, you give anticoagulation.
Yeah, I mean, if we have floating aortic thrombus or intramural thrombus in the heart, we need to give them anticoagulation.
But this one usually give you a big emboli. They don't give you Bluetooth syndrome. Again, as I said, Bluetooth syndrome is atheroma. It's not a clot. You know, so usually you see a disease arteries. You don't see like a thrombus. You see like a shaggy aorta. You know, calcified arteries, disease arteries. It's not like a normal artery with a floating. You know.
Yeah.
So it's a trash. It's the atheroma. The reason why we don't treat them with anticoagulant. Usually we treat them with antiplatelets. What else we give with antiplatelets?
Statin.
What is that?
Statin.
Statin. Why statin? It stabilizes the plaque, right? So
Yeah.
this is a plaque emboli. So it stabilizes the plaque. So usually we give statin and antiplatelets. Okay.
Okay.
Okay. Again, simple question. Let's go to the next one. We go back to Ahmed. Want to take this one, Ahmed?
All right. A 72-year-old man with past medical history of hypertension, hyperlipidemia, and 40 pack year. Smoking history presents with a chief complaint of painful blue discoloration of the toes in his right foot. Blue toe syndrome. The symptoms started suddenly 3 days ago and have progressively worsened. On examination, his sinus rhythm is normal, not affected. The affected toes are cyanotic and cool to touch. There are no signs of systemic infection, and the patient has pedal pulses palpable, Bluetooth. The ankle brachial index on both indices on both sides are normal, 1.1. The patient is currently on long-term anticoagulation with direct oral anticoagulants after a similar episode with the left toe that led to partial amputation of the toe. Imaging revealed an atheromatous lesion in the descending thoracic aorta, the figure. Which of the following is the next step in management of this patient? There is a descending aortic floating thrombus. And the patient was started in DOAC before, and this is the second event. We need to do something about it.
Right, because he already on DOAC and second event. But if both are wrong, not, what do you do?
I will start with DOAC.
Syndrome, and he never had any episode, you know, and he never be anticoagulation. Then what do you do with this patient?
Start with DOACs.
Yeah, most of the times they dissolve with the time. But in this patient, he already was in DOAC and he already had a second episode. That means he failed, right?
Yes.
So he failed his medical management. But if he just saw him like that the first time he come, I put him on anticoagulate because of floating clot, as Samer mentioned before, or Abdullah, sorry. And then put anticoagulant, and then we watch him, you know. And then if they get a second episode, you know, that means they failed, then we think about it, you know, to treat this one. And how we treat it?
This is the descending thoracic aorta. Endo is an option, or open, but endo is less invasive.
What is the best option? What's the best option? If you get the best option, what is the best? TIVAR. Okay. You know what's the difficulty with this kind of patient with difficulty? I mean, did you see something like that? You have the case TIVAR for thrombus like that?
No, I did not see.
Yeah. You see, when you see it, you can tell. Does anybody knows what the problem with this kind of
Showering.
patient?
Showering.
No, no, it's not
Squeezed
showering.
up,
What's that?
squeeze up with the stent.
No, no, no. You got to find it. Because
Yeah,
the
صح
angiogram, you don't see.
صح الانجيوجرام
It's very
2D.
small thrombus, and the angiogram looks normal. You don't know where it is. So we're going to say here, you see it because it's a CT scan. We do an angiogram because the contrast above and below is floating. So it's up above. So the angiogram, the contrast is above it or below it. So you do an angiogram, it looks normal. That's what I had a problem last time when I did just one case like that, and the angiogram is normal. So where it is, because I have to put my T-bar, I don't put it in the place where there's not a clot. And I can't go blindly. So in this case, I use an IVAS. The best way to use an IVAS. That's what I did. So in this case, I think at least have it as a backup, make it ready. Because if you don't see it in angiogram, sometimes it's very large, you see it, but sometimes you don't see it, especially if it's small. I will put an IVAS as a backup. Then, but the IVAS, you can see it very nicely, IVAS, Then you know where exactly, and then you can just put TVAR. And they do just well, okay? All right. I had a patient who has a TVAR before from car accident, and about like 10 years ago, and he came with, but not clotted, he came with multiple emboli to the legs, acute ischemia. We did thrombectomy, we do angiogram is normal, nothing we see. Then he go for 2-3 months. He came with other emboli. We do thrombectomy, angiogram, nothing there. I think he came like 4 times. He's a young guy. And we thought he's resistant to heparin. We changed it, and we changed DUAC. We put him on warfarin, put him on Clexan. We changed it to get hematology, and he's getting back with emboli. And we never figured out. And finally, we look at his CT, and then we found that TVAR, the old TVAR, was forming a clot in the wall of the TVAR. This is the reason why he's getting record emboli. The one we found that in one of the CT scans, we're lucky to see it. Then we went there and put another TVAR inside the old one. And since that time, he's been doing fine. So sometimes it's very hard to find where the source is, It's not always obvious. Even when they come from the heart, because the time they come to the heart, they already left the heart, so heart will be empty, normal, Anyway, so again, remember, guys, if you have to do TVAR, keep IVAS as a backup. Let's go through the question, sorry. Let's go through the answers.
Okay, continue his anticoagulation and high dose statin. Well, this is a failure of a treatment.
Okay.
Then thoracic endovascular aortic repair. This is what we suggested, TVAR, the segment, or open surgical repair with descending thoracic aorta. We're in the 21st century.
Yeah, but let's see what the question is. The best question following is an extent. Okay. Yeah, I don't think nobody will do open these days for this case. It's the vascular is much better. Yeah. Okay.
Open surgery, and then the catheter-directed thrombolysis. What is the indication?
Yeah, why they just do thrombolysis, right? Why don't do that? Because it will not work. Because if you put it in the aorta is very large, right? If you do thrombolysis, it will go all the way down to the legs. We're not going to stay in the aorta to dissolve this clot, you see? It's different when you deal with the legs, where it's a small artery, 2, 3, 5 millimeters. Aorta is about like 2.5 centimeters. So if you do thrombolysis, and the whole aorta is not like if the aorta is thrombosed, it's different. If the aorta is open, you just have small clot in the wall. All the thrombolysis will not work because it will go down to the leg, will wash away, so it will not work. So in this case, it will not work.
And then catheter-directed thrombolysis of the right lower extremity. Then you fix the symptom, not the original problem.
No, because you don't need it because he has a normal pulses, right? He has a trash syndrome, right? Let me see. Yeah, palpable. See? So what is a Bluetooth syndrome? So thrombolysis on the legs will not help. It's a Bluetooth syndrome. Microemboli, so will not work. All right. Any question about this one?
What if the thrombus is in the arch itself?
Well, this one looks like an arch, You have to look at the CT and look. He said it's an aorta, but really this is an arch. Unless if it's like curving down. Now, could be. No. Sorry, this is not. This is the thoracic aorta, right? It's just curving down. It's like tortuous. The reason why it looks like that. So this is descending thrust. If it's an arch, it depends. I mean, you have to look for risk and benefit and decide how easy to fix it and how is easy or complicated, you know. But usually the arch, most of the times they give emboli to the brain, I think. But you have to go case by case and decide, you know. Yeah. Any other question? Okay.
Yes, Dr. Samer.
Yes. Go back.
This
Yes.
patient, if you put the stent, is there any risk that you push this thrombus up to the brain or to the subclavian or while you are pushing the device?
Well, yes, always a possibilities, but you just have to be careful. But yes, always possible it could happen. But again, I mean, you are in surgery. If something happened, went down, you can do thrombectomy. That's why I have to do compression angiogram when you finish, you know, and use an IVAS. But it's nothing you can avoid it. But I will not do surgery just to avoid doing that because surgery is major surgery, you know. So I will still go with TIVA. Yes, it's a possibility. You have to tell the patient it's possible you can move when you do it. So we have to do open thrombectomy. If we went to the celiac, we have to do open, you know, thrombectomy. So you have to prepare for the worst scenario because there is a risk, yes, but still doesn't prevent you from doing TIVA. Okay, as a first choice.
But pushing it up to the carotid or because if it goes to the lower limb, to the visceral.
This is distal thoracic aorta. This is distal thoracic aorta, you know. It's not like all the way at the arch. If the arch is possibility, but also remember now we are in 21st century. Even if you go to the brain, you can do. I mean, within 4 hours, you can do thrombolysis. You are in tertiary care hospital, so you can go and do. You know, you can do thrombolysis or pull the catheter from the brain. It's not a big deal. If you want to be on, like, if this one in the arch, I'm worried about it. Then I put a filter, the double filter. You know, go from the radial artery to with double filter in the common carotid artery. What do you call this device? Sentinel filter. So if you do sentinel filter, the people they use when they do TAVI, the cardiologists, they use sentinel filter. It's 2 filters. They go from the radial. It's very simple, by the way. I use it a couple of times. Very simple. You go from the radial, has 2 filters. One stay in intimate artery, and one stay in the left common carotid. So you are protected. Then you go and put your TVAR. And this will not be in your way because you go from the right radial artery. Did you see it before? Farah?
No.
No?
No.
I mean, you should see it if you. We have it here at King Faisal's. Let me see if I can show it to you. Did you read about it? Did somebody heard about it? Sentinel. It's called Sentinel filter. It's correction. No. During TAVI. During TAVI. Here it is. Let me share the screen. I can change the screen. You see it here? Let's see if it works. See, guys? So,
Yes, we can see.
see it? Yeah. Let me see if they can tell you how to do it. So you go from here, see how it works? So then curve it up. You see, you go there, you deliver first, then you curve it up, you deliver second filter. It's very simple. Do it again. So you go from the radial artery here. It has like a screw. You open the filter. Then you can bend this one. It has a screw, goes up. You put your wire up. Then you advance your second filter. That's and stay there. And then you do your arch. Then you do whatever you have to do in the arch. And when you finish, you do the opposite. You collapse this one, pull it back, collapse that one. and you're done. Any question, guys?
Because now if they deploy the TVAR stent, how are they going to retrieve it?
No, you can't retrieve it. It's not problem. It is very simple. 6 French, you know. You see it's here. TVAR is here. You see how it's high? Especially if you go. I mean, it depends where it is, but it is very simple catheters. It can come, it's very easy. It's just 6 French, not like a huge. So even if you have a TVAR, you can retrieve it. All right, let's go back to our question. Where is it? All right, any other question for this question? Maybe we take one more question, guys. Almost 9 o'clock. Let's see. What's the last question? 36. Who's now? I forgot now. Who's now?
Me, I'm the one.
Lara? Go ahead.
32-year-old athletic man presented to the clinic complaining of calf pain after starting to play soccer. He stated that he has been playing sport all his life, but over the last few months, he has noticed more pain in his right calf than his left immediately after he started running. During the peak of his symptoms, he felt numbness in his right toe, but all symptoms resolved after he slowed down his pace. He denied smoking and did not report pain while at rest. What is the most commonly expected finding on the physical exam?
What do you think he has? 32 years old. You know, when he runs, he gets the symptom. When he stops, the symptom goes away.
Yeah, this is Entrapment syndrome.
Yeah, Traven syndrome, right? It's straightforward. So how we make a diagnosis? By physical exam.
Dorsiflexion or disappearance of the
Yeah.
pulse with dorsiflexion of the foot.
So let's go through the question. It's a simple question, really. Let's go quick through that.
So absence of pedal pulse on the right foot at rest? No.
Yeah.
Discoloration of the tip of the first and second toes? No. Loss of pedal pulse upon passive dorsiflexion or active plantar flexion of the right foot? Yes. Pallor and coolness of the right foot at rest? No. Loss of 2-point discrimination in the right foot? No.
Yeah. So I think this is a compartment syndrome. I mean, just straightforward, you know. They like this syndrome. They always ask about this one, you know. So in lower extremity, most of the question will come through like compartment syndrome, acute ischemia, fasciotomies, you know, emboli, atheroma, something like that, as you saw, you know. All right, guys, we now want to have, do you want us to continue next year? Sorry, Saturday. We're going to do Saturday, okay? Do you want to continue lower extremity or go to Venus?
We want to go to the Venus.
Do Venus, okay.
Yeah.
Any question about lower extremity before? I don't think we'll go back to it anymore. Maybe we had really 36 questions. All the questions are similar. We cover most of the lower extremity really things. Again, I mean, the most important to know is the basal trial and best CLI trial, you know, because which one you have to do bypass, because it's, the main controversy in lower extremity is endovascular versus surgery. And all trial talking about it. So trying to consider those two trials, you know. Comparison thromboBTL, entrapment, they love these questions, you know. Sciatic artery, persistent sciatic artery, they like this question. They like the rare things, you know. Okay, any questions before we leave?
يعطيك العافية دكتور شكرا.
Saturday is a good day for you guys, Saturday?
It is.
Today is good. Today is good.
Good?
Yeah.
Okay.
Yes.
We'll meet Saturday, okay? Meet Saturday.
Thank
Thank you, everyone. Take care, guys.
Thank you.
يعطيك العافية
Thank you.
دكتور شكرا. Thank you.
Salam.
you.